Everyone, welcome to Patho Excellence. This is our endometrial pathology series where we simplify pathology with clear histology, key exam points, and clinical relevance. Endometrium is the dynamic tissue in the human body. It undergoes predictable cyclic changes every month under the influence of hormones. For us as pathologists, understanding these normal morphological changes is the foundation for interpreting endometrial biopsies in infertility, abnormal uterine bleeding, and in detecting precancerous or malignant lesion. In this series, we will take a step-by-step approach to learn the cyclic phases of the endometrium, their microscopic hallmarks, and the clinical relevance of endometrial dating. The first episode is of normal endometrium. Then next topic will be endometrial dating. So let's start first anatomy and histology. In this, here this is the specimen of uterus. The cut surface shows endometrium lining the uterine cavity, myometrium, and serosa. Outer surface is serosa. There is a part of cervix, and this is the lower uterine segment connecting to the cervix. So endometrium, which is hormone responsive mucosal layer lining the uterine cavity, it composed of glands, specialized stroma, and blood supplied by spiral arteries. Then myometrium, it is made up of smooth muscle cells, and the outermost layer called perimetrium, which is made up of loose connective tissue and mesothelium. This is low power view of a histological section of uterus showing endometrium, myometrium made up of smooth muscle cells, and this outer layer is perimetrium. Now, what are the components of normal endometrium? So first is surface epithelium. This epithelium is continuous with the glandular epithelium, and it is the innermost layer of the endometrium where it lies in the uterine cavity. This layer is less marked cyclical variation than the cells in the glands, and it is frequently ciliated. Second, stratum basalis is the deepest layer of the endometrium, which is a minimally hormone responsive and serves to replenish the stratum functionalis following menses. This layer is less responsive to steroid hormones and typically shows irregularly shaped, inactive appearing glands, dense stroma, and aggregates of spiral arteries. These arteries have a thicker muscular walls than those in the functionalis. So here you can see in this section, this is the basalis layer demonstrating weak proliferative glands, which is tubular in nature, and it is less responsive to hormone. In this high power view, you can see single layered cells lining the tubular gland. Then stratum functionalis. It is the hormone responsive superficial layer of endometrium, undergoes functional and morphological changes throughout the menstrual cycle, and it sheds during the menses. Usually endometrial glands are regularly spaced and have a perpendicular arrangement from the basalis to surface. This layer is subdivided into the superficial compact layer called stratum compact and deeper spongy layer called stratum spongious, and this is only striking in the late secretory phase or post-ovulatory or luteal phase. See here, this is the surface epithelium. This is the stratum functionalis, and this is the basal layer. Here you can see these glands are regularly spaced and they are perpendicular to the surface epithelium and to the basalis layer. Stratum compactum. It is a thin region beneath the surface epithelium in the post-ovulatory phase. Here the glands are straight and narrow, less responsive to hormone, even when the glands in the functionalis are tortuous. In stroma, it is a superficial compact layer having dense arrangement. It responds remarkably to the hormone stimulation with the prominent pre-decidual reaction and numerous granulated lymphocytes. And stratum spongiosum. It is the middle layer of the functionalis, consists of glands showing maximal secretory activity but relatively unresponsive stroma that does not develop a good pre-decidual response apart from the immediate vicinity of the spiral arterioles. Here you can see this compact and spongy zone. So this is surface epithelium. The upper part of this functionalis is called compact zone, and this spongy zone consists of numerous secretory endometrial glands, and this is the lowermost basalis layer, and this is the myometrium. So compact zone mostly seen in the late secretory phase at the day 27. And here you can see these glands are small tubular compared to the spongiosis. So this is less responsive to hormone as compared to spongy zone. Now the endometrium merges with the mucosa of the fallopian tube at its upper extreme and with the endocervical epithelium at its lower end. The junction with the fallopian tube epithelium is usually abrupt, although the exact position may vary, and uncommonly this lining of endometrium sometimes going some centimeters lateral to the cornu, and it is referred as endometrialization. Endometrialization is different from the endometriosis. Endometriosis is where the endometrial glands reaches into the myometrium. Here, the glands reaches to the fallopian tube or cornu of lateral to the cornu of uterus. Endometrium from the uterine body and fundus is generally fairly uniform from one area to another. Now, glands of the lower uterine segment show practically none of the morphological effect that hormone stimulation elicit in the fundus. So, care must be taken to recognize this tissue for what it is so that the inactivity in this species is not taken to mean that the endometrium as a whole is not being stimulated or it's not responding. In lower uterine segments, the glands are generally weak to proliferative. If we receive endometrial biopsy from this segment, then we may mismatch the date because of its unresponsive to hormone stimulation. And in general, we are receiving material from all these layers routinely, and so that pathologists must be aware of characteristic appearance at all sites throughout the menstrual cycle. Here you can see lower uterine segment part in the section where the stroma and glands having having endocervical gland as well as the endometrial gland. So this is endocervical gland having mucinous epithelium, and this is the weak proliferative tubular glands of endometrium. So here you can differentiate lower uterine segment by more fibrous appearing more fibrous appearing of stroma and more cellular than the endocervical tissue. So this is endocervical gland, and here you can appreciate endometrial gland. Now let's see different components of glandular cells we can appreciate in endometrial biopsy. There are three types of endometrial glandular cells. One is secretory cells. These cells are by far the most abundant and their morphology varies with the time of the menstrual cycle. Second is the ciliated cell. These cells are more frequent near the cornu and towards the endocervix, as well as being quite common in the surface epithelium. Although normal constituent of the endometrium, these ciliated cells are particularly under the influence of estrogen and become more prominent in conditions of estrogen excess. So during an ovulatory cycle, the ciliated cells are more prominent in the endometrium. Then clear cells. Clear cells are much less common and are thought to be precursors of the ciliated cells. They are most frequently seen in the proliferative phase. So here you can see secretory cells. They are lining all the glands of the endometrium. These are the surface epithelial lining cells which are ciliated in nature. And here you can appreciate these are the clear cells. They are lying in between the secretory cells and they are thought to be producing ciliated cells in the gland. Here you can appreciate numerous clear cells lining in between the secretory cells. So they are clear, having clear cytoplasm and small vesicular or sometimes prominent nucleus. In this section, you can appreciate this is the clear cell and this is stratified gland showing mitotically active nuclei. Now, second component is stromal cells. The morphology of the endometrial stromal cells varies dramatically throughout the menstrual cycle. So, during the proliferative phase, the stromal cells are small and mostly compact with oval hyperchromatic nuclei and inapparent cytoplasm and resemble fibroblasts. In the mid-proliferative phase, where there is a peak of serum estrogen level, these stromal cells are separated by increased intercellular edema and show mitotic activity. So this is a section showing mid-proliferative phase with markedly edematous stroma and mitotic activity. At the end of the proliferative phase, the nuclei become slightly larger and their chromatin is a little less dense. Now, in early secretory phase, they have a spindle shape and slightly vesicular nuclei. Stroma again become edematous in the middle of the secretory phase, reaching a peak at about 22nd day of a normalized 28-day cycle. After which, the cell of this compact zone progressively undergo pre-decidual change. Means there is development into polygonal cells with vesicular nuclei, abundant pale cytoplasm with well-defined cell borders. So pre-decidual change, pseudodecidual change and residual change. These three terminologies are important. So term pre-decidua is generally used to describe the changes in the morphology of the stromal cells in response to endogenous progesterone, and pseudodecidual change is the morphology in response to exogenous progesterone. Now the term decidual is properly reserved for the changes seen in the pregnancy. So decidual change is more extensive and uniform in pregnancy and in patients receiving exogenous progestin. Whereas in premenstrual endometrium, a significant proportion of the cells are only minimally or partially affected. Now, decidual change is first apparent adjacent to the spiral arterioles. Towards the end of the secretory phase and in pregnancy, the change becomes diffuse. The stromal cells are situated deeper in the endometrium, lying between the active glands of the spongy layer, show little decidual change and remain fairly nondescript. Now, what is the role of this decidualization? So, the decidual cells of the endometrial stroma, together with exponential increase in the granulated lymphocytes and natural killer cells, and the synthesis of variety of cytokines and extracellular matrix proteins, including laminin and fibronectin, play a central role in process of nidation. So, it means they prepare endometrium for implantation. Here you can see the stroma, which is very much edematous in nature, having fluid in between and clear looking appearance of the stromal component in presence of glands of endometrium. This is basalis, this is functional layer, this is surface epithelium, and this is edematous stroma. Here you can appreciate surface epithelium, and beneath this surface epithelium, this is stratum compactum. In stratum compactum, the stroma is well responsive to hormone and it shows pre-decidual change, showing vesicular nucleus and abundant eosinophilic cytoplasm with boundary. Here you can appreciate spiral arterioles. So as we have discussed, in compact layer, the stromal cells are well responsive and show pre-decidual change with abundant cytoplasm. This is a cell, stromal cell, showing abundant cytoplasm, and these dark nuclei are granulated lymphocytes. And here, this gland is having less responsive to hormone and less secretory change as compared to the zone of spongy layer. So here, this gland of spongy zone shows maximum secretory change, while the stromal cells are having small in appearance and very less cytoplasm as compared to the compact layer. So here, stroma active, here gland is active. Here gland is less responsive to hormone. Here stroma is less responsive to hormone. This section shows markedly decidualized endometrial stroma after exogenous progesterone therapy. So this is a atrophied gland and the stroma shows markedly decidualization, showing abundant cytoplasm with clear boundary and round vesicular nuclei. Now, third component is endometrial lymphocytes. So, several subpopulations of T lymphocytes generally reside in the normal endometrium, and some small lymphoid aggregates are normal, particularly in the basal zone. Macrophages are normally found in the functional and basal zone. CD4 plus and CD8 plus T cells are randomly scattered throughout the functional layer, and in endometritis, their aggregates near and around the glands can be seen within the gland lumen along with the CD68 plus and CD163 positive macrophages. B lymphocytes are normally sparse in the endometrium, and neutrophils are not seen in normal endometrium until menstruation is well established. So, their presence at other times of the cycle indicate inflammation. So, here you can see the stratum basalis containing a lymphoid follicle. So, this is a normal finding in the stratum basal. Now, another important component is endometrial granulocytes, or another name is endometrial granular cells or A cells. These are the small rounded cells with hyperchromatic nuclei that are usually kidney shaped or segmented, increase in number in the endometrial stroma in the second half of the cycle. These cells are known as endometrial granulocytes, endometrial granular cells, or K cells. They are not polymorph, but they are granulated lymphocytes. Their cytoplasm contains eosinophilic granules of variable size, and so that they are mistaken for infiltrating polymorph nuclear leukocytes, particularly in the presence of early or imminent menstrual fragmentation. This cell exhibits the unusual T cell phenotype CD56 positive, CD3 negative, CD16 negative, and also have a natural killer cell function. These are called endometrial natural killer cells. They increase in number dramatically in the late secretory phase of the menstrual cycle, and sometimes reaching a population density exceeding 25% of all stromal cells. If conception and implantation occur, they continue to increase in number and make up about 70% of stromal lymphocytes in the first trimester of pregnancy. And these cells are distinct from other classes of natural killer cells, having both a major immune regulatory function and a critical role in remodeling of the endometrium after implantation. So here in this section you can see abundant number of large granular lymphocytes in pre-decidia of normal late secretory endometrium. These are having hyperchromatic kidney-shaped nuclei and some granules. So these are dark hyperchromatic large granular lymphocytes, and these are the decidual cells of or stromal cells showing pre-decidual change. Now, last component is blood vessels. So, uterine artery gives a branch called arcuate artery, which is supplying myometrium. Then there is radial artery, which divide into basal artery and spiral artery. This basal artery supplying the basalis layer, and this spiral artery, it supplies the whole thickness of endometrium. In the secretory phase, under the influence of progesterone, the spiral arterioles become prominent and coiling become more pronounced when the stromal edema is reobserved prior to menstruation. In the proliferative phase, these arterioles show little coiling and they are confined to the deeper levels of the functionalis. There is irregular network of venous channels with the veins frequently intersecting, forming venous legs, and lymphatic vessels present in the normal endometrium, but these appear in decidualized endometrium during pregnancy. So here you can well appreciate spiral arterioles in the early secretory phase, and surrounding this spiral arterioles there is starting of predecidual change in the stroma. Here you can appreciate edematous stroma. Here there is predecidualization stroma, and this is gland showing secretory change. So basically, when you the slide in microscopy, you first identify this surface endometrium. Then this is the stratum functionalis. In secretory phase, this portion is called stratum compactum, and this is stratum spongiosum. This is stratum basalis layer, and this gland here show perpendicular arrangement to the surface and basalis, and this is the myometrium. So next episode is endometrial dating. Stay tuned. Thank you.